Our session is an interesting one because we are discussing about the common mistakes in management of dyspepsia, hepatitis B, and ulcerative colitis, and we have a very good panelist of speakers, including Professor Altaf Alam, Professor Gasuddin Nabi Tayyib, and Professor Shahid Sarwar. Our first topic is common mistake in management of dyspepsia, and it is going to be delivered by Professor Shahid Sarwar, who is head of department and dean of gastroenterology and hepatology at Namakon Medical College, and he's going to deliver his first talk. I hand over mic to Dr. Shahid Sarwar.
Thank you, Dr. Iftikhar. Let me share my. Can you see my presentation? Dr. Iftikhar, we can see in terms of while managing patient of dyspepsia. And then we'll see what is the quality of evidence for the recommended pathway in the guidelines. And that will decide, or these are areas of controversial decisions. And obviously from there, we will get the way forward. Now, what can be the potential decisions which can go wrong in somebody who has presented to us with dyspepsia, and we are managing that, we are planning for diagnosis and management. The first thing that can be controversial here is who should be diagnosed as dyspepsia, especially if we are talking about functional dyspepsia versus undiagnosed dyspepsia or unworked up dyspepsia. Then when to perform an endoscopy, another area of a big controversy, and obviously where decisions can go wrong in these patients. Then how to handle the patients who also have got alarm symptoms in addition to presence of dyspepsia. And we'll also talk briefly about the management options, because there are 4 or 5 major management options. In most of the guidelines, you will see H. pylori, test and treat, proton pump inhibitors, prokinetics, antidepressants, and psychotherapy. So in what order these management options should be played, and what is the evidence in favor of their benefit? That will decide that what option should be at the second priority, and which decision is right or wrong. But remember, when you're talking functional disorders, at the end of the discussion, you may end up with more questions rather than answers. This possibility will remain in these disorders. So from where we can look for the right decisions. Obviously, the guidelines, American College of Gastroenterology guidelines of 2017. I have included Korean guidelines, which are of 2020. And the special reason for including these guidelines is that the Korea has got the highest incidence of gastric malignancies. And the management decisions are something that we are going to take in the background of the fact that in patients of dyspepsia, we can be potentially missing the cases of malignancies as well. Then we have got NICE guidelines, a bit older, but still holds true for this time. And we have got Rome 4 classifications, which is very good document for definitions of different functional disorders. First thing, who should be diagnosed as dyspepsia? So what is the definition of dyspepsia? If we look at these guidelines, what they suggest is anybody coming with epigastric pain, which may be associated with fullness, nausea, and vomiting and heartburn, and the duration of symptoms is for more than 1 month, can be labeled as dyspepsia. Now, with this definition, there is a big problem. You have got a big group of people who are presenting with epigastric pain, and a major chunk of that is of functional dyspepsia, who are just not going to have any organic cause. But there is a significant proportion of people with epigastric pain who are going to have organic diseases as well. And that can range from peptic ulcer disease, esophageal reflux disease, malignancies, motility disorders, infections, infiltrative disorders, motility disorders, drugs, endocrine causes, mesenteric ischemia, chronic pancreatitis. These potentially lethal complications can present with epigastric pain. And when you go back to the definition, that just needs an epigastric pain to be present for more than 1 month. So we need to be very cautious here, because we may be missing a major serious diagnosis if we are just focusing on the definition of dyspepsia. So how to exclude that? Obviously, history, age, weight loss, dysphagia, melena, we know these examination, if you get palpable hepatinomegaly or mass or ascites, that should divert you away from the dyspepsia. But we know many of these organic diseases may not have any symptom or anything suggestive on history to straight away jump to the diagnosis. So the only thing which can change functional dyspepsia is upper GI endoscopy. So for functional dyspepsia, you need normal endoscopy. If you go to Rome 4 classification and patient coming to you with postprandial fullness, early satiation, pain, burning of more than 6 month duration and of more than 3 months of with normal endoscopy can be labeled as functional dyspepsia. And we know they have classified this further in postprandial distress syndrome and epigastric pain syndrome. That is the predominant symptom. Is it epigastric pain or burning at least once a week? Or is it postprandial fullness and early satiation at least 3 times a week? So that will decide is it PDS or is it EPS? But most of the guidelines take this classification not very seriously because there is a big overlap between these two symptoms. And if you go through the guidelines, there is not much of a discussion regarding the management of EPS or management of PDS, more of a theoretical classification of patients with dyspepsia. So the bottom line is, unless you have performed an upper GND, you cannot diagnose a patient with functional dyspepsia. This patient will remain a patient of dyspepsia with a potential of having possible organic disease. So the implication will be that if you don't get response to the treatment, if you have anything which is harming, you always move toward working up this patient further rather than labeling it dyspepsia and wasting time for 6 months, 1 year, and coming up with a surprise after 6 months or 1 year. That's the first area of concern. That's the first area of mistake which needs to be avoided in patients before labeling them as dyspepsia. The next question is when to perform an endoscopy in these patients. If I go by guidelines, the age of limit, age is used as a major barrier, major limit for deciding regarding endoscopy. But this barrier has been raised over the time from 45 years to 55 years. And now in 2017 guidelines, what they are suggesting is that performing an endoscopy in somebody with dyspepsia less than 60 years of age is not cost effective. And they are saying it is only above 60, then when we should go for endoscopy. But remember, this recommendation is conditional to clinical evaluation, conditional to clinical judgment, and the quality of evidence is still low for this recommendation. Because the question rises is it applicable to all populations? Because there is a big meta-analysis from Taiwan of more than 17,000 patients. And that was done when the age for endoscopy in dyspepsia was 45 years. And they have identified that more than 5% patients of gastric malignancies are of less than 45 years of age without any alarm symptoms. So age barrier will depend on prevalence of malignancies. And if you see the Korean guidelines, they recommend endoscopy in every patient above 40 years of age with dyspepsia. And they have found it cost effective as compared to H. pylori test and treat policy. They are recommending first do an endoscopy without organic causes, then go for H. pylori test. So where do we stand? This remains a gray zone for us because this will need evidence. This will need evidence of prevalence of malignancies over here and evidence of what practice, what age limit is cost effective in our population. Till then, this will remain a gray zone from 40 to 60 years. Where should we decide? And for right now, our decision is going to be based on our clinical judgment. And we should be very careful in refusing an endoscopy in somebody less than 60 years of age before a detailed clinical examination and history. And if you feel, you may go ahead with the test, further tests as well. So another thing which is used for deciding regarding the need for endoscopy is alarm symptoms. We believe patients with alarm symptoms should have an endoscopy with symptoms of dyspepsia. And these are the alarm symptoms all of us know very well. And these always should be asked in the history. It's like age and persistent pain and weight loss and GI bleed and vomiting and dysphagia. These are the symptoms which need to be explored. But how do the guidelines look at these alarm symptoms? So American College of Gastroenterology does not recommend endoscopy for somebody with less than 60 with alarm symptoms. And what's the evidence? There are 7 good randomized controlled trials with more than 46,000 patients, and they have seen overall risk, relative risk is 2.74% of having malignancy with alarm symptoms. But if the age is less than 60, this risk goes down below 1%. So what they believe is that the positive predictive value of these alarm features is very low. So they cannot be used as an indication for endoscopy. Instead of that, they suggest that rapid weight loss, more than 20 pounds in 6 months, and worsening worsening dysphagia is more of an evidence in favor that this patient may have an organic cause for his dyspeptic symptoms. What if age is less 60 and patient is not responding to the treatment with or without alarm symptoms? Obviously, then endoscopy is something which is indicated. And even if that is normal, that is recommended to review the history, examination, then you can proceed with your test, complete blood count, biochemistry test, keeping in mind the list of organic causes that you have. Before that, you will consider the other treatment options for dyspepsia before jumping onto these options of further workup in these patients. What if endoscopy is normal with age above 60 years of age and patient has alarm symptoms? Should I label it as functional dyspepsia or I need to further work up? Again, it will be clinical decision. If you go through the guidelines, there are no clear-cut pathway that you will identify. They suggest the next test should be an ultrasound abdomen followed by imaging test. But still, what they identified is that the evidence is very low, and the chances of having malignancy in a very large populations is less likely. But that's the clinical decision that you have to make. So when I talk about need for endoscopy, cutoff points for endoscopy, this remains the guideline, but it needs data on prevalence of GA-related malignancies. That will only decide, is it cost effective to perform endoscopy at 40 years or is it cost effective to perform endoscopy at 60 years? And obviously age limits are going to be different in Asian populations, especially in populations which have got high incidence of GA-related malignancies. And patients with alarm symptoms should be carefully evaluated regarding the need for endoscopy. Now that was for the workup. And now I'll talk about the treatment options which we have in this dyspepsia. But I remind again that without endoscopy, diagnosis will be dyspepsia, not functional dyspepsia, or it is also called as undiagnosed dyspepsia. So if there's no need for endoscopy, then the first treatment option is H. pylori test and treat, and the recommended tests are stool antigen and urea breath test. Obviously, patient should be off PPIs for the last 2 weeks. What is the evidence for this? The relative risk reduction is 0.81%. You need to treat 7 patients to get benefit in 1 patient with H. pylori test and treat policy in a patient of dyspepsia. So one of the things that comes to your mind is, why not go ahead with endoscopy first and then do an H. pylori test testing? Even there are very large trials, 6 trials, more than 2,000 patients. Persistence of dyspepsia 7% after 1 year in H. pylori test and treat policy and 7% with endoscopy. And 25% of the H. pylori patients ultimately have an endoscopy over the next 1 year. And what in this meta-analysis was that at least 3 H. pylori should be given to decide regarding the benefit of H. pylori or not. So another option can be, first we rule out the organic causes and then we decide to give H. pylori test and treat policy. When you look at this evidence, you have got randomized controlled trials, and persistence of symptoms after 3 to 12 months is still 67% with H. pylori eradication and 76% if you are not giving anything for that. And number of needed to treat is 12. What I want to focus here is look at the evidence we have. Look at the quality of evidence is very good, but the benefit is only marginal here. There are other meta-analyses and you will see the similar picture. There is marginal benefit of treating with H. pylori in patients with dyspepsia, and placebo has a very high rate of response when you compare it with the treatment policy. So then naturally, the question comes into your mind, why don't we go for the second option first, which is proton pump inhibitors, instead of treating with H. pylori for patients of dyspepsia. Now there are trials, 4 trials, more than 1,500 patients. Persistence of symptoms after 1 year is 73% with H. pylori policy, test and treat, and 78% with giving PPI first. Difference is not significant, but there is trend toward symptom improvement and cost effectiveness in favor of H. pylori test and treat. What they have concluded is H. pylori test and treat policy is better if the prevalence of H. pylori is more than 20% in the population. And if the prevalence is less than 15%, PPI may be a better option as a first line dyspepsia. So again, you see still the evidence is good. The evidence is strong. They're very good studies, but the benefit is marginal. So H. pylori test and treat will remain a first treatment option for undiagnosed and even for functional dyspepsia. And probably good prognostic factors identified here in few studies are symptom duration less than 5 years. If you find an erosive gastritis and endoscopy, there are more chances to be benefited by H. pylori treatment. But obviously, in areas of high H. pylori levels like our area, the concerns will be side effects of the treatment, device recurrence of infection as long as the hygienic conditions remain same in that particular area. What if patient is not responding to evidence? There are 6 trials, more than 2,500 50% of PPIs continue placebo. And here you need to maybe there are few studies which have shown PPIs are more effective in epigastric pain syndrome rather than postprandial distress syndrome. Discontinue PPIs if patient is not having any benefit after 8 weeks. Continuing treatment will not benefit this patient. And if the patient has benefit, you will continue that treatment. And every 6 to 12 months, you will try to discontinue that. But difficulty with functional disorder is that whenever you try to stop the treatment, there is always recurrence of the symptoms. And whenever you're talking about long-term PPIs, obviously these side effects, hip fractures, pneumonias, electron imbalance, these comes to mind. But studies have shown numbers needed to treat to get these side effects is more than 1,000. So that's not a major concern. Major concern is the cost of treatment and longevity of the treatment and in-response that you get in most of these patients. Can we use beta blockers? There are studies which have shown there is not much of a difference, but the quality of evidence is low. And beta blockers have got a problem of tachyphylaxis, that their response to treatment that diminishes over time. So not much favored in patients with dyspepsia. What about prokinetics? We are using so many prokinetics in dyspepsia, and most of this use is based on expert opinion. What are the different prokinetics? We know these domperidone, levosulfuride, metoclopramide, but they have got a long list of side effects, and many of them are not approved in many of the countries. The only D2 receptor antagonist which has not shown extrapyramidal effects or has minimal prolactin release is itopride. And there is marginal benefit, but again, the quality of evidence is very low. So guidelines on this use is not very clear, and it's more based on expert opinion, basically. Then we have 5-HT4 agonist, fundus relaxation drugs, 5-HT1 agonist, but mostly these drugs have side effects. Mostly they are not approved in many of the countries, and the quality of evidence is low enough to not give a clear guideline. So in prokinetics, I think instead of mistakes, it's more of a controversial issue. And why we are using it, because we don't have much of the benefit with H. pylori, with PPIs are not that robust. So we are looking for new drugs. Probably this area will remain open for discussion and controversies. Another drug which is used in dyspepsia, tricyclic antidepressant. There are studies which have shown its benefit, but remember they are only used in all of these studies have used it in functional dyspepsia, not in undiagnosed dyspepsia. There is no benefit of SSRIs. There are few trials which have shown there is no benefit in patients with dyspepsia. So this is what we have right now as a recommendation, but we all need to remember the quality of benefit that we see in all the evidence that has been given behind this particular guideline. So we are going to follow these guidelines, but we'll keep all those things, all those limitations which are there. And obviously in such situations, your clinical judgment, clinical experience, and your perception regarding patients does matter. And you should always remain open to workup and further investigations. You don't want to miss a critical and very sinister diagnosis just thinking that this patient has dyspepsia. So the management plan will remain same in functional dyspepsia, apart from the fact probably tricyclic antidepressants are above prokinetics, but still the evidence is very low quality in these cases. So what I can conclude is that mistakes stems from lack of evidence. So we still don't have very clear direction in management of dyspepsia. And diagnosis needs normal endoscopy and more than 6 months duration if you are going to label functional dyspepsia. Otherwise, it will remain undiagnosed dyspepsia. Otherwise, it will remain subject to possibility of critical, serious diagnosis as well. Decision of endoscopy should be based on cost effectiveness, which needs local prevalence of GI malignancy. So again, this is an area which will need a clinical judgment to make decisions. Alarm symptoms should be carefully evaluated for need for workup, diagnostic workup. H. pylori treatment and proton pump inhibitors are still the first line treatment option, despite marginal benefit in high quality evidence. Antikinetics and TCAs, they are treatment options, but for refractory cases, despite there is low quality of evidence and concern for side effects. Thank you very much.